Hello, I'm Ileana Pina from Central Michigan University, and this is my blog. Here we are at the American College of Cardiology National Meeting, which once again this year is virtual. However, the late-breaking sessions, I think, have been fabulous, and I've been watching most of them from early in the morning. And one of them that went on this morning was from my good friend Delane Kidsman, who is professor of medicine at Wake Forest and now is the Phillips Chair of Cardiovascular Medicine at Wake Forest. Since I've known Delane, he has been consumed with chasing heart failure with preserved ejection fraction. And I think he knows more about the syndrome than anybody else in the country that I know of. And his other love is the geriatric cardiology. And he's really invested his entire career. And we've known each other longer than we both want to admit. He has been absolutely faithful to what he loves to do. And today he presented a very fascinating, to those of us who are in cardiac rehab, REHAB-HF, something that has been talked about, discussed since we came out of HF Action. So Delane, welcome. Thank you for taking the time to come and join us. And the first thing I'm going to ask you is give us an overview of the trial. What were you trying to accomplish? What did you accomplish? And then we'll go deeper into it.
Thank you, Ellie. I'm honored to be here. REHAB-HF was built on the observation that older persons hospitalized for acute decompensated heart failure have very poor outcomes, with frequent rehospitalizations, poor quality of life, high death rate, and a range of interventions aimed at improve their outcomes have been neutral. This suggested to us that something has been overlooked, and we hypothesized that perhaps it was severe physical dysfunction. Indeed, our preliminary data suggested that these patients had very severe physical dysfunction and high rates of frailty, and in domains that we had not anticipated: poor balance, poor strength and mobility, in addition to the endurance deficits that we anticipated. So we assembled a group of rehabilitation experts who helped us design a novel rehab intervention specifically to meet the needs of these patients. It addressed all four domains, balanced, including balance and strength and mobility, before we undertook endurance. That was an important key, because geriatric studies have shown if you take frail patients like this and subject them directly to endurance training, you have poor efficacy and you frequently have injuries and falls. The intervention was one-on-one, it was tailored, and it started in the hospital, then transitioned to the outpatient for 12 weeks, 3 times per week. We had a home-based assessment also to make sure it was safe for home exercise. After 12 weeks, we transitioned then to independent home exercise for another 3 months. And what we found was, first of all, we had excellent retention and adherence. We think that may be that patients really appreciated how frail they were and how much this was helping them. Fully, 83% of patients reported continued home exercise at the end of the study. Our primary outcome might be unfamiliar to cardiologists, but it's very familiar to geriatricians: short physical performance battery, which was developed by the National Institute on Aging, has been used in many large trials, is currently being inserted into clinical practice, and is a validated, very brief 5 to 6 minute measure of global physical function. At baseline, our patients had SPP scores of 6.1. Give you a perspective, this is the average you see in a nursing home population. This is on the threshold of not being able to take care of yourself. At the end of the 3-month outpatient intervention, those in the attention control group increased just mildly to 7.1, confirming our hypothesis that these patients have long-term disability, don't get better on their own. However, in those randomized to the rehab intervention group, there was a large, statistically significant 1.5 unit improvement in SPP, be 3-fold higher than that associated with minimal clinical difference. We also found large improvements in 6-minute walk distance, 34 meters when the threshold for meaningful It's 34 meters, but these patients only had 196 meters at baseline, meaning that proportionally it was 20%, quite large. A large improvement in KCCQ quality of life score, 7.1 units when 5 is significant, and also improvement in depression and frailty. However, we didn't find any improvements in our secondary outcome of all-cause rehospitalization or heart failure rehospitalization or death. In fact, I need to point out that numerically there were more deaths in the rehab group. This was not statistically significant and the number of events were small, but we believe that that's a signal that needs to be explored further.
Were you powered for mortality, Jillian?
We really weren't. We knew going into this that in reality, we had a phase 2 clinical trial. And our fearless senior leader, Chris O'Connor, repeatedly told us with 349 patients, even though your pilot data make it give you confidence that you have a chance to get the clinical outcomes, just be prepared that if this one is positive, we're going to need to have a phase 3. And of course, Chris was right.
Well, and I would strongly support that because I think there's more here than meets the eye. So let me make several observations. First of all, everybody thinks that just getting the patient out of bed and pushing them down the hallway, making them walk, that's it. That becomes rehab in the hospital, and something that I have argued with for a long time. And that, they need to go to the skilled nursing facility. So looking at our numbers in heart failure, the number of patients being sent to skilled nursing facilities rather than home after an acute heart failure hospitalization has tripled, which is rather amazing. And you would think that the skilled nursing facility is just going to follow the same thing that you've been doing. Well, that's not the case, as we well know. So several of my questions. First of all, I have to compliment you on this adherence. You and I had pains about our adherence on HF action. What do you think was so significantly different from the HF action population that you had such wonderful adherence?
Well, we were gratified by that. And of course, the Achilles heel of all exercise interventions is always adherence. I think there were 3. The first was that the home environment assessment. And it wasn't just looking around at the home, it was also the community and the neighborhood that was in. We met with important social support persons, so engaged family, friends, and neighbors.
Who did that? Who did that? Did the investigator?
That was the interventionist that went out to the home. So they really knew what was, as you remember in HF Action, we did go to the home, but we just merely set up equipment. But this was a full-fledged assessment of what Amy Posfett calls the built environment. It includes everything that could influence the patient's behavior and willingness and safety. And so that right from the beginning, we encouraged them and taught them how to do home exercise safely twice a week. And then during the 12 weeks of the outpatient session, we reinforced this repeatedly. We asked them how they're doing at home. We helped them overcome barriers so that by the time they finished their 12 weeks and went into 3-month independent, they were well prepared. There was another, and that is we had something called this Sustaining Patient Engaging Committee. This was a brainchild of Pam Duncan, Amy's POSFA. Every 2 weeks, we got together, all of the interventionists, the study coordinators, and as many as the PIs would join, and we troubleshoot. We did troubleshooting on each and every patient. We tracked them, and we shared success stories and challenges and overcame them. A third thing is that our patients reliably told us how much difference this made to them. Some that were barely able to get up, and later they were able to resume what for them was normal activity. They valued this and they wanted to be able to continue it. So I think those were 3 key ingredients that helped us get such a good retention and adherence.
And your centers were yours in Wake Forest. You had Philadelphia was one of your centers?
Yes, Thomas Jefferson was our 3rd hub. And then similar to the HF Action, we had satellites. So there were 4 satellites, 2 associated with Duke and Durham and 2 associated with Jefferson in Philadelphia. That means that 4 out of 7 sites were community hospitals in small to medium-sized towns. And I believe that helps boost our generalizability in the ability that if we confirm this in a phase 3 trial, to roll this out and make it a really practical intervention.
So do you think if Medicare takes a look at this, you think they're going to fund, as you and I well know, because primarily your population was HFpEF, your mean ejection fraction, I think it's in the 50s. So it's not the low EF population. Do you think Medicare is going to pay?
We don't think so, and it's not. That is not our goal. Here's the reason: 53% did have HFpEF. As Illy, as you know, in the HF Action trial, with 2,133 patients and a positive signal for events, you and I and other HF Action investigators had to campaign for 5 years. We meet repeatedly with CMS and provide numerous additional analyses. We don't have that. And we actually believe that, as encouraged as we are with these results, that in order to truly convincingly change clinical care guidelines and certainly reimbursement guidelines policy for what is in reality a pretty expensive and intensive intervention, we're going to need events data. And we can get that. Here's why. You mentioned HFpEF. I am authorized by Chris O'Connor to announce to you today the results of our subgroup analysis on EF. And as you know, New England Journal of Medicine does not allow secondary subgroup analysis of secondary outcomes, but in press to be released electronically soon. And Jack Heart Failure shows the following really surprising and encouraging trends. In the HFpEF patients, they had substantially more severe physical dysfunction, frailty, quality of life, and depression. And when exposed to the intervention, they appeared to have consistently more benefit, sometimes up to 50% more for SPPB, 6-minute walk. Now, and also when we looked at clinical events, something really surprising. For hospitalization, there was a not even move the needle 1% lower hospitalizations in HFrEF, 17% lower in HFpEF. For death, amazing. And I've got to be cautious here because we were not powered for these.
Well, understood.
But how about in death? There was a 35% lower death rate with HFpEF, 250% higher in HFrEF. These were not, and interestingly, the interaction p-value was actually significant for death. Most of the others, I need to caution, the interaction p-value was not significant. It got pretty close for some of them. So we saw overall very encouraging trends. But before we say, let's rush out and take all hospitalized HFpEF patients and let's do this, I would have to caution, this was an exploratory analysis.
Yep.
It only included 92 patients who were with HFpEF that were exposed to the rehab intervention. So as encouraging as these are, we don't believe that we can claim that this is ready to insert into into clinical practice. But I can tell you that the investigators are working very hard to plan and seek funding for a subsequent phase 3 trial, which we are hopefully would be positive and would bring this into routine clinical practice the right way, with definitive evidence and hopefully with compelling evidence that would compel payers to cover it.
I think the NIA should be very interested in this as they funded this study for you.
A shout out to the NIA. They were visionary. NHLBI, who also are our friends, said they were supported, but said, "What is SPPB?" So anyway, again, but shout out to Jerry Flagg at NHLBI and many others who supported HF Action. But NIA really
Definitely.
embraced REHAB-HF and saw that this was very well aligned. And we hope that NIH will be enthusiastic about a subsequent trial, but we're just in the planning stages right now.
So I think for our audience, just to remind our audience that very often the mortality cause for HFpEF is one of their comorbidities. It isn't necessarily cardiac or sudden death. And then if you want to tie that to the inability to care for yourself because you can't get out of a chair, the 6-minute walk distance here should scare the bejeebies out of everybody. It's one of the lowest that I have seen. And we know anything below 300 is severely impaired, and yours were in the hundreds. I mean, this is awful. And yet you had high pro-BNPs. I looked at your pro-BNPs. So the patients had been pretty sick with higher pro-BNPs. And so the clinicians, when you're sending these patients home, at least get them physical therapy, if anything, in the home, and talk to the families about doing it together. And I know it's very hard to get up. For me, some of my older ladies who are overweight and very incapacitated, but dangling the carrot that you may not need long-term care if we can get you moving and you can take care of yourself. I mean, that should be a huge carrot to promote independence. So there are a lot of things linked in here. And of course, you mentioned behavior, and I think so very, very true. Well, I can't thank you enough for having done this, because I think it's very revealing for all of us. And the fact that balance, there you go, balance, how important it is to get up and move. The get up and go that some geriatricians have used and tested tells you a lot. If you have balance issues, you're not going to be able to get up and go and get out of the chair. And then you add the fear of falling to that, which is a whole other component. Well, we look forward to Dr. O'Connor's lauded Jack heart failure paper. And we look forward to reading the New England Journal paper. I really congratulate you, Delane. And to our audience, I hope we left you with some good pointers. This is very interesting and applicable to your own care. These patients are not going away. The numbers are going up even as we speak. I thank you for joining me today. This is Ileana Pena signing off. Have a great day.